My Scholar Topics presentation is over autosomal dominant disorders. Specifically, we're going to discuss Noonan syndrome and Marfan syndrome. To begin, as an overview, we will first discuss autosomal dominant and give a quick introduction on what that is. Then we'll go into the genetics and genetic testing for both disorders. And then we'll talk about specifically Noonan syndrome, then followed by Marfan syndrome, and then conclude with management techniques and a comparison of the two disorders. So, introduction: autosomal dominant disorders are genetic conditions that are inherited through the non-sex chromosome. Each child of an affected parent has a 50% chance of receiving that trait. And I also wanted to share that there are over 7,000 different genetic conditions labeled under autosomal dominant disorders. Some other common ones you might have heard of are polycystic kidney disease, Huntington's disease, and achondroplasia. And these are some photos of Noonan syndrome and Marfan syndrome. Now we will go into the genetics that play a role in autosomal dominant disorders. So first, a geneticist can do FISH testing, which FISH stands for fluorescence in situ hybridization, and it's used to identify specific DNA sequences within a cell or tissue sample. This is best if the patient is in the hospital and there is a potential for them to have an autosomal dominant disorder, because it only takes 3 days to get results back. The second testing they can do is a dysmorphology exam, which is basically a head-to-toe assessment used to identify and interpret patterns of human growth and structural defects. The National Human Genome Research Institute provides a list of dysmorphology exams for almost every single disorder. So it's kind of like a checklist that geneticists use to narrow down what disorder the patient might have. The next one is the next generation sequencing, which can sequence billions of DNA fragments in parallels. So there's the genome, which analyzes the protein coding regions of genes to find genetic causes or conditions. And then there's also the rasopathies panel, which analyzes genes that specifically affect the RAS/MAPK pathway, and that is specific to Noonan syndrome. And lastly, they'll also do a family history 3 generations back to see if this is truly an autosomal dominant disorder. On our next slide, these are photos that kind of help describe, and you can kind of see what the testing involves. So there's the FISH test, the dysmorphology exam, like I said, that is kind of like a checklist that they can mark off and see how many defects the patient has. And then also the next generation sequencing, and then the family history. Next, we will discuss Noonan syndrome. Noonan syndrome affects 1 in 1,000 to 2,500 live births. It's a disorder caused by mutations in one or more genes that disrupt the RSA-MAPK cell signaling pathway, and that pathway specifically deals with growth, differentiation, and survival. This disorder affects both males and females equally. People with this disorder can have congenital heart defects that occur in about 50% of cases. Normal lifespan is to be expected, but depends on severity of findings and which ones they have specifically. More recently, it's described as a spectrum more than a syndrome, and it has also been known to be named the male Turner syndrome. Noonan was named after Jacqueline Noonan, who was a pediatric cardiologist who discovered the disorder in 1968. The manifestations that are seen with Noonan syndrome are down-slanted eyes, flat midface, webbed neck, short stature, small chin, wide-spaced nipples, a single palmar crease, congenital heart defects, a short broad nose, delayed puberty, bruising and bleeding disorders, and chest deformities. To be diagnosed with Noonan, you must have one major manifestation, and what's classified as a major manifestation is the cardiac defects, the chest deformities, the short stature, and a family history, or you need 2 minor manifestations. Some eye problems that may be seen with Noonan are strabismus, which is lazy eye, nystagmus, which is rapid eye movement, and amblyopia, which is reduced vision. The congenital heart defect that is specifically related to Noonan is pulmonary valve stenosis, and that affects around 50 to 80% of individuals with this disorder. Now we will switch over to learning about Marfan syndrome. Marfan syndrome affects the connective tissue in a patient. This prevalence is 1 in 5,000 live births. The tallest person with Marfan was 8 feet 11 and a half inches. Some famous individuals that had Marfan allegedly was Abraham Lincoln, and Michael Phelps was formerly diagnosed with Marfan syndrome. Normal lifespan is expected, and half of people with Marfan are unaware of their diagnosis. Marfan was named after Antoine Marfan, who was a French pediatrician who discovered the disorder in 1896. And many professional athletes, including basketball players, swimmers, and volleyball players, have Marfan syndrome. The manifestations of this syndrome include a tall, slender build, disproportionately long arms, legs, and fingers, high arched palate and crowded teeth, heart murmurs, specifically aortic dissection and mitral valve prolapse, extreme nearsightedness, abnormally curved spine, flat feet, and chest abnormalities. So the aortic dissection and dilation that is seen with Marfan can lead to aortic aneurysm, which can be life-threatening. Marfan is also specifically a FBN1 mutation, which is related to the connective tissue. And some eye problems along with nearsightedness is patients may have astigmatism and a dislocated lens, which is caused by the fibers that hold the lens in place weaken due to the connective tissue. Next, we will talk about the management of both. For Noonan syndrome, some management would involve PT, OT, and speech therapies. You can have heart surgery to correct any anomalies. Growth hormone therapy can be useful to address the short stature that is seen. Tutoring can help with learning disabilities. Regular follow-ups for heart monitoring are very important. Yearly vision and hearing exams. Support groups for both patients and families, and consultation of a genetic counselor in order to get early management tips and tricks. For Marfan, they might need PT and OT therapy, preventative surgery to repair the aorta, eye exams, medications to lower blood pressure to reduce strain on the aorta, joint surgery to treat chronic pain from osteoarthritis, and also support groups for patients and families and consultation of a genetic counselor. Next, we'll go into the comparison. So some Noonan-specific characteristics and things we learned about is that they have short stature, learning disabilities, pulmonary stenosis, and it involves the RAS-MAPK pathway. So Marfan-specific is the opposite. They have tall stature. They usually have normal intellectual abilities. Compared to pulmonary stenosis, they have aortic dilation, and it is related to the FBN1 gene, which is the connective tissue gene. And some similarities that they have is they're both autosomal dominant. They both have certain vision changes, and they also have and are known for their distinct facial features. And these are my references. Thank you for listening.